Good morning to you all viewers. My name is Njabulo Ncube. I'm a PhD candidate at the University of East Anglia. We are working on a project that is funded by the Institute and Faculty of Actuaries here in the UK, working on using big health and actuarial data for modeling longevity and morbidity risk. Looking basically on the impact of diabetes mellitus 2 on longevity and morbidity risk. My presentation is going to follow the following outline. I'm going to give an introduction to the research, where I'm going to define what diabetes is, and then also give the types of diabetes, then followed by the current levels of diagnosis as defined by NICE, an organization here in the UK, and then also name a few complications of diabetes, and then from there why we have chosen diabetes as a disease of study or research. And then we are going to also discuss on the study design, where you give a brief outline of how our study design is, and then we'll look at a few statistics, the exploratory results of our study currently, and then from there we'll give the next line of work that we'll be doing in our research. As of now, I'm gonna move on to my presentation. Okay. By definition, diabetes mellitus is a chronic metabolic condition characterized by frequently increased levels of blood glucose. And there are two main types of diabetes, which is type 2 and type 1. Type 2 is when the body is unable to effectively make use of the insulin it produces, or it's producing less insulin than needed by the body, which results in higher levels of blood glucose. And this type of diabetes constitutes 90% of all diabetes in the UK. The second type of diabetes is type 1. This is when the body is unable to produce any insulin at all as a result of damaged insulin producing cells, and it constitutes 8% of all diabetics in the UK. There are other several types of diabetes, which includes impaired glucose tolerance, gestational diabetes, impaired fasting glycemia, and this constitutes about 2% of all diabetics in the UK. For one to be diagnosed with diabetes, one has to have a frequent blood glucose level measured in HbA1c, shortened for glycerated hemoglobin, and the level should be greater than or equal to 48 millimoles per mole. So when one's blood glucose level is not controlled, what happens? One suffers from a number of diabetes-related complications, or one has a premature death. These complications, they include sight loss, amputation, cardiovascular diseases, which include stroke, heart failure, myocardial infarction, and peripheral vascular diseases. And then also one can suffer chronic kidney diseases, some cancers, and cognitive impairment, including dementia. Why diabetes is of interest in our research? This is premised on the statistics that have been produced of late by the World Health Organization, and we see that from the slide. We can see that in 2000, diabetes was ranked number 15 among the causes of death globally, and it was associated with 944,000 deaths. In 2005, it moved 4 levels up, and it was number 11, and it was associated with 1,135,000 deaths. In 2010, it moved a level up to be at number 10, and it was associated with 1,311,000. In 2016, it moved 2 levels up to number 7 from 2010, and it was associated with 1.6 million deaths. And also from this graph, you can see that the first 2 causes of death globally, ischemic heart disease, stroke, and also you've got COPDs, and also Alzheimer's disease and other dementias. These are complications of diabetes. It might be possible that one can probably die out of those top 5 complications of diabetes, but the underlying cause, it will be diabetes mellitus. Now, in the UK, we can see that as from 2011, there has been exponential increase in the number of deaths that have been associated to diabetes mellitus, which is of concern. And also globally, you can see that the number of diabetes patients is on the increase, and sadly, also it's now including also the young ones. They are also now being diagnosed with diabetes 2. In the past, diabetes 2 was a disease that was diagnosed in the late ages. Now, coming to our study description, we can see that our study is designed to derive, analyze, and model the impact of diabetes mellitus 2 on longevity and morbidity risk. And the data that we are using was extracted from one of the primary databases here in the UK, the THIN database. And we got a subset of this database for the patients who were born before 1960. And our study follow-up period is from 1986 to 2016. In terms of selecting our cases or those who are diagnosed with diabetes, we used the first diagnosis, the earliest of the first diagnosis, or the first prescription date as the diagnosis date. The reason being that sometimes doctors they record prescriptions earlier than a record of the diagnosis. So because of that, a human error or probably human kind of error, you will find that some other diagnosis codes are recorded later than the prescription records. And so it will be very important for us to also include those patients who have got prescription records which are earlier than the diagnosis code. And because diabetes is an insidious disease, so it is also paramount importance to include also prescription records in taking into account the selection criteria. After selecting our records, we managed to get 108,282 cases. And I'm saying cases, I'm referring to diabetes mellitus 2, those patients who are diagnosed with diabetes mellitus 2. And then out of these, we matched them using 1, 2, 3 by practice, age, and sex, and we got 253,800 controls. The primary outcome of our study is all-cause mortality, and then also we are going to look at the incidences of amputation, cognitive impairment, chronic kidney disease, heart failure. In particular for chronic kidney disease, we are mainly focusing on CKD 3 to 5, stages 3 to 5. They've got heart failure, myocardial infarction, peripheral vascular disease, stroke, cancer, and dementia. For our study selection, this is the criteria that we used. We looked at every diagnosis of diabetes which was recorded or done. The first diagnosis was greater than or equal to 1986, and the patient should have been aged 40 years and above. And also the transfer date and the death date, they should be greater than the entry date. And also of interest is that the patient should have been registered in the practice for at least 12 months prior to being diagnosed with diabetes mellitus 2. And we also excluded patients who had severe health conditions, stroke. In particular stroke, we left patients who had TAI, transient stroke. And then we excluded all patients who had dementia, all forms of dementia, patients who had CKD 3 to 5. We excluded all patients with all forms of cancer, and then cognitive impairment, those who had lower limb amputations, peripheral vascular disease, heart failure, myocardial infarction. We also excluded those who had severe health conditions in those diseases before the entry date. Now we look at the statistics that we have in terms of the data that we managed to extract from the subset of the THIN database. We can see that most of the males, they are diagnosed with diabetes mellitus 2 between the ages of 55 and 64 years, while for females, they are diagnosed a bit later, between the ages of 60 to 69 years. Because we left some patients with some conditions that are of interest in our study, so we can see that we have got also patients, we have got less severe heart failures, myocardial infarction, PVD, stroke, and amputation and cognitive impairment. The reason being that we need also to make sure that our study population can also be generalized to the UK population, so that the results can be applied in insurance or in government when they are making their policies in terms of the UK population. We looked also at the survival, the Kaplan-Meier plots with respect to the Townsend score quantile. The Townsend score quantile is one of the deprivation index that is used here in the UK, with 1 associated with less deprived areas and 5 associated with most deprived areas. We can see from our slide that for those in the less deprived areas, controls yet a lesser survival probability compared to the controls. But as we moved on to most deprived areas, we see that controls had a better survival compared to controls. This may be attributed to the fact that cases, they frequently visit doctors to have their blood glucose levels monitored, and in so doing, they also get assessed in terms of any risk that they might have, diabetes complications, maybe big stroke. They get checked their BPs, they get checked their the level of some other biomarkers like the GFR to assess the functionality of the kidneys. This is also a level that can be used in the diagnosis of CKD. So we can look also from the top right corner. We have got the hazard ratios that we also got using the reference group as the control. We can see that those with in the less deprived areas, they have got the cases. In particular, we mean those who are diabetic. We have got diabetes mellitus 2. They've got a higher risk of mortality compared to controls. But as we move on to the most deprived areas, we see from the hazard ratio, which is 0.72, which means that the cases, you have got 28% less risk compared to controls of mortality. We also compared cases to cases with respect to the deprivation areas using the less deprived areas as the reference point. And you can see that when those were in areas that are associated with quintile 2, we can see that those were aged 50 to 59 and also up to 70 years and above, they're at a higher risk of mortality compared to cases in Townsend score quintile 1. But as we move also onto the higher quintiles, we can see that, or the most deprived areas, we can see that cases have got a higher risk compared to cases in the less deprived areas. In particular, you can see that those were diagnosed at ages 40 to 49, their hazard ratio was 1.28. Those were diagnosed at ages 50 to 59, they had 38% higher risk of mortality compared to those who are in less deprived areas. And then those diagnosed with 60 to 69, 14% higher, their risk was 14% higher. For those who were diagnosed with at ages 70 years plus, their risk was 7% higher. We also compared the cases and controls with respect to the time it takes them to be diagnosed with conditions of interest in our study. In particular, here we are presenting cancer, dementia, heart failure, myocardia, and stroke. We can see that for cancer, controls were at a higher risk of all forms of cancer compared to cases, and also for dementia and stroke. But the opposite is true for myocardial infarction and heart failure. We can see that for myocardial infarction, the cases were the cases yet a higher risk of being diagnosed with myocardial infarction and being diagnosed with heart failure. In particular, for cancer, the reason why we have cases having a less risk of being diagnosed with cancer is because of the drug that they use. One of the drugs called metformin has been found that it has got some anti-cancer effect that might be attributed because of that drug. And also for stroke, because they get checked their blood pressure, they get checked their cholesterol levels, they get checked all sorts of biomarkers, which are also probably related to stroke. They get their Q risk is also checked each and every time they visit the doctors, so they get a better medical service compared to controls, because controls they visit their general practice less than those who have got diabetes mellitus. If you have to look at the hazard ratios for the selected diseases, we can see that the earlier one is diagnosed with diabetes mellitus, the higher is the risk of one having an amputation compared to controls, and also for one to have a cognitive impairment, and also for one to have a chronic kidney disease compared to controls. Now, if we look at the CVDs, the cardiovascular diseases, we can see that the same trend also that we saw on the previous slide is the earlier one gets diagnosed with diabetes mellitus 2, the higher is the risk of one suffering a heart failure, a myocardial infarction, a PVD, and also for stroke. You can see that the rates, the hazard ratios are very, very low, which means that controls are at a higher risk of being diagnosed with stroke compared to those with diabetes mellitus 2. Now we move on to the next step of our work. We are going to look at the full case of our data. What I mean by full case is there are some variables which are of interest to us, but because of the data that we have got some missing values. So we'd want to select all the patients who have got complete data, and we do our analysis. We have a module on the on the patients with complete data, and then so that we'll be able to compare with the data which are going to the model that we are going to get after we do an imputation. So as I've said, the first level we are going to do a full case modeling, and then we'll do imputation, and then after imputation we come up with the model after imputation, and then we compare the full case model and the imputed model, and then after that we will translate the models into actuarial context. This will be there to help those in the actuarial field and also in the insurance in terms of coming up with actuarial fair prices, and also in terms of their reserves, so that the business remain viable and also the clients are also happy and satisfied with their products. I would like to thank you all for listening to our presentation. I hope you loved our presentation, and if you've got any questions and any comments that you'd want to give us, please don't feel free to also visit our website that has also been presented by one of our former presenters. I thank you all. Have a good day.